Hi, I'm Lisa. I am with the SHARE project here in Haywood County, and we have been doing a series of interviews to bring awareness to resources in the area, resources that are treatment centers, recovery facilities, those types of things, people that provide services to the area. And SHARE stands for Spreading Hope and Awareness and Removing the Epidemic Stigma. And we've been trying to highlight each of those words with these interviews. Spreading hope, spreading awareness, and removing the stigma. And today we are touching on all three of those. We're spreading awareness about a recovery center in the area. We're talking about addiction and substance use, which means we're doing our part to destigmatize those things. And we're spreading hope because there is hope. There is hope for recovery. I am with Nicole Ross today. She is with Behavioral Health Group Recovery here in Haywood County. I believe there is also a facility in Buncombe County,
yes,
but we're talking specifically about Haywood County today. So I am going to let Nicole take it away. She's going to start just by telling us a little bit about herself, a little bit about her educational background, and just telling us more about yourself. So take it away.
I'm Nicole Ross. I'm the Program Director at Behavioral Health Group Recovery. And today the office that we're really focusing on is our Clyde office, because I want to make sure that we're highlighting resources that are for our Haywood County folks.
Yes.
As you can tell from my accent, I am from this area, born and raised in Haywood County. I'll move away every few years and then move back. The mountains get in your blood, and you just can't get them out. So my educational background, my master's degree is in traditional counseling, and so my background was education and nonprofit work. So that was kind of where trajectory was heading. I grew up in a Haywood County middle class, lower middle class family, great upbringing, good roots, and as many of you know, addiction is no respecter of person. So I grew up in a family where addiction was not talked about. People had their problems, but you didn't talk about that. As long as you were sitting second pew, piano side at church on Sunday morning, then everything was fine. We just don't talk about it. So we lost my brother to substance use disorder in early 2000s or mid 2000s, and that was when my family started talking about things.
Okay.
And
how old were you at that time?
I was 25,
okay.
25, 26, and it was really those early days of people talking about substance use disorder. People would mention, that they had an alcoholic in the family, or that they had somebody who had trouble with pills, but nobody wanted to say, hey, this is a disorder. This is something that is affecting all of our kids and all of our families. It wasn't long after that I found myself in the same throes. One of the proudest roles I have now is that I'm a person in long-term substance use recovery. I have 13 years.
Yes, excellent.
Thank you.
Yes,
I'm pretty proud of that.
Yes, you should be.
And so when it became clear that that my family was going to be enmeshed with substance use, whether or not we wanted, I decided in the way that I typically do, is that we're going to talk about it. And so I decided, you know what, professionally I can do this too. So that's how I ended up kind of switching from the general education piece to substance use counseling.
Okay.
Was A, personal experience, and B, the family experience, and C, just the need.
Yes.
One of the things I've always found that I'm good at is making people uncomfortable and sitting with them in their discomfort. And no place is that more welcome than substance use disorder, because there's so much shame and so much stigma around that. So just being willing to be uncomfortable and have those hard conversations is kind of what I thought, ooh, that's my field. Yeah, that's where I want to be.
And so how long have you been doing that as your line of work?
6 years now.
Okay.
Right at 5 or 6 years. Kind of once we got through that first hump of early recovery, and I was no longer staying home with kids, and it was like, well, let's redirect. So I entered back into the substance use field. Had no intention of doing it in Haywood County. And was very specific about that. And now I look back and I think, boy, I really missed an opportunity.
Yeah. And why?
My thought was that I wanted people to feel comfortable getting treatment, even if they knew me. Like, I didn't want to be a face that they thought, I might be ashamed of talking to her.
Yeah.
So then I decided that really the best way to counter that is just by opening up and saying that.
Yeah.
Like, hey, we can be a safe place. I can be a safe place. And that was what prompted me really to share my own recovery story rather than trying to hide that.
Yeah.
Because my desire to help and to provide treatment resources in this county has nothing to do with judgment and everything to do with, I've been there.
Yeah.
And know what a gap there are in resources. And the gap in resources for women and mothers particularly is what led me to this field. So I started volunteering with Project Cara at Mayheck, which is their perinatal program for substance using mothers. And so when I kind of came out on the other side, it was like, okay, well, I can give back in this tiny way. And so I got asked to be an advocate on that board. And that was kind of like tiny little glimmer of, hey, you could do this. Hey, you could do this. So that's what led me back into this field. So when the position came open for program director for Clyde, I was like, that's my backyard, and you bet I'll take it.
Yes. So that is your position then, program director.
Program director at the Asheville and Clyde office.
Okay, and what does that job description look like then? What does your day-to-day look like?
Well, I'm still managing a caseload, so I have about 10 clients at each facility that I still see. I get to be picky now, so typically I prioritize pregnant women and parenting mothers. So those are my babies. And one of the questions that you asked earlier was, what keeps you going? My mamas and their families are what keep me going, because parenting is hard. Parenting as a person who's also trying to rebuild your life is daggum near impossible if you do not have a good support.
Odds are totally stacked.
So getting to work with those moms and those families and saying, treatment's possible and recovery is possible, and what does that look like for you? What is this going to look like in the landscape of your family? And to help them have those same discussions with their children, because lots of times when you're parenting, it's messy and your kids are seeing the messy and you don't want to hide. Recovery is about living out in the open, and so how you communicate that to your children and your family members, and how to advocate for themselves and what they need within those family systems. That's what really gets my blood flowing.
Wow, yeah, I can tell.
Yeah.
Okay, so we know a little bit then about your background, what led you to BHG Recovery, Behavioral Health Group Recovery. What do they do specifically?
Okay.
And go ahead and tell us what they do, and then we'll kind of break that down a little bit of what that actually looks like to somebody walking in the door.
Yes. We are what is called an OTP, which is an opioid treatment provider, which means that in-house we provide methadone or Subutex, counseling services, individual, group, and family, and medical care. So we look at diagnosis and treatment for Hep C, HIV, those kind of things. So at our heart, we are harm reduction. We're just trying to help folks make better choices today than they did yesterday in a safe way. So one of the things that I've been really thankful for with BHG is their willingness to kind of push the envelope against that stigma of that methadone clinics have to be dose and go. Because I think there is that myth still in communities and families that if we're providing methadone, it's just a methadone clinic and it's dose and go. And it's not. It really is a comprehensive plan of counseling, of social supports, of medical care, of different diagnoses, and getting them hooked up with different providers in the community that they need, different social supports, things like that. So OTP is just comprehensive opioid treatment provider.
Okay, got it. Yeah. Now, when somebody comes to you, do they already know that they want to get methadone?
Sometimes.
Or are they just know that you're a recovery center, they see the sign, they come in and they see what or do they kind of already know? They know that this is the only form of treatment for just for opioids.
Yes, it is just for opioids. I have hopes that in the future we're going to see medically assisted treatment for methamphetamine and stimulant use disorder too. However,
I've seen some
let me be clear,
research on that.
I'm not a medical provider and I don't have FDA backing it yet, but I am hopeful that in the future we're going to see that too. Because there are, statistically we know that return to use is lower if we can engage opioid users in methadone, Subutex, Vivitrol, naloxone, all of those pieces. Like if we can add that as a tool for them, then it helps support their recovery. And typically recovery rates are higher and outcomes are better. So when someone comes to us, typically they're going to go through a phone screen, and we're just going to make sure that they're appropriate for treatment. You know, if we have somebody who's just using alcohol and methamphetamines, they're probably not appropriate for treatment. It's rare we see that. Most of the time when we are working with folks, they already know, hey, I have issues with opiates I have used in the past year. And really, that's our requirement is, are you or have you used opiates? And are you ready to do something different than you did yesterday? Like that's, you got a willingness. So people, it's not even a willingness to change. It's a willingness to question whether or not this is working for you.
Yeah.
Because a lot of times people aren't ready to change on day one. Day one may look like, I don't know, but I know this isn't working.
Yeah.
And so we can just kind of meet them where they're at and support them.
Right. Let them know there are options.
Absolutely.
And what those options would be.
Yes. So then they're going to meet on day one, they're going to meet with a therapist. They're going to do a biopsychosocial assessment, which is really, it boils down to, I tell people, you're going to answer a lot of questions today that are super uncomfortable and that you're going to think we don't have any need to know. But I promise it's all for a purpose. That's going to help us determine what level of treatment they need. Do they need inpatient or detox before they come to us? Because sometimes that's necessary.
Can refer that off.
We absolutely do. We will Uber them to ADACT with their referral packet already there. We have everything ready to get them hooked up with inpatient resources, especially if they don't have insurance or if they're underinsured. Yeah. Because a lot of times, you can call that number on the back of your insurance card and say, hey, I need treatment. But what about our folks who don't have those? So we can be a good, a hub. Yeah. If somebody's not appropriate for our care at that point, we can get them to where they need to go. Yeah. They're also going to meet with the medical provider that day. They're going to, most of the time when people come in, they're going to know, hey, I've taken methadone on the street. I know that works for me. Or they're going to know, hey, I've taken Subutex on the street and I know that works for me. If they don't, we have had some people come in and be like, I don't know what I need. Yeah. Great. That is what our medical provider is for. One of the things I really appreciate about him, and it's Dr. Nathan Mullins, is that he has this amazing ability to listen and respect what that person's experience is. He respects that, listen, you've been self-medicating for the better part of a decade. Yeah. Why don't you tell me how you're feeling? What's worked for you? What's not worked? What are you trying to numb? What is it? Chronic pain? Is it, and so we can get a good assessment then on that day of kind of what the person's needs are. Then we're going to set them up with a primary counselor. We're going to draw labs. We're going to do urinalysis. We're going to do the whole 9 yards that day, just so we can get an overall picture of where they're at and what they need. My favorite part as program director is getting to play matchmaker with counselor and client. And I'm like, hey, let's look at your biopsychosocial. Let's see, who would you be a good fit with? Yeah. Because the thing is, if you were to call today, if you were to look online and find you a therapist, if you were to go to 2 sessions and you're like, this isn't a good fit, nobody's going to force you to go back. Right. The thing with treatment facilities sometimes is that if it's not a good fit in the beginning, people just tough it out because they're like, well, I don't have any other choices. Yeah. Listen, we've got enough therapists that if it's not a great fit, I want to fit you with somebody who is. Yeah. Like, I want you to have the same choices that anybody else would have, even if they could pay a buku dollars for their treatment. Yeah, because I think that's where respect and mutuality come in.
Well, and I would imagine that some of them not only tough it out, but some of them leave.
Yeah. Oh, absolutely. And I don't ever want us to be that bare, and you never know what's going to feel right for somebody. They may have somebody that looks like their great Aunt Beulah and they're like, I just don't like her. And that's fine. Yeah. We've got enough therapists that we can switch that around because we want you to be comfortable, whether that's in an individual or a group setting.
Right. One quick question before you continue with the procedure. Does someone have to be off the drugs before? Do they have to be sober, in other words? Okay, so they can still be actively using when they come in the door and ask for help.
Absolutely. Okay. And I tell people, we're not going to judge you, whether your last use was a week ago or in the parking lot. Yeah. Like, I'm just thankful that you did whatever it took to keep you safe to get here. Yeah. And if that was use in the parking lot or if that was use last week, that's fine. We can work with that. Yeah. And then, from there, they're gonna see their counselor once a week. They're gonna see
this question.
They're gonna see their counselor at least once a week.
Okay.
I don't more if you need us.
Right.
That first week is tough.
Yeah.
That first month is, and especially now that Medicaid is allowing telehealth, like I'm loving it because people have access to, support and therapy that they might not have had.
Yes.
If a mom is struggling midday, she knows, hey, you know what? I'm gonna call my counselor. I'm just gonna chat through this. So we're able to provide services in the moment as they're struggling through these triggers. Awesome. It's been a really cool thing. I'm not thankful for COVID
to stick. Would you say, or at least some balance of that?
I do believe that there's some balance there. Because I think now that it's out of the bag,
that's it, and it's proven itself that it is a benefit. I think it will.
Well, and for our folks who don't have access to great transportation, they can work their way up to take homes, and so if they're only coming in once a week, but they need to talk to their counselor 3 times a week, then that's not a barrier to treatment then. So I'm loving that telehealth piece.
Yeah, that's great.
Yeah.
Okay, so you've gotten them referred, they're fitted with their therapist, their counselor, they come once a week. If I am right about methadone, they have to come every day for at least a little while.
For 90 days.
Okay. And of course, you're giving them a dose that is appropriate for their need, their size, whatever that would be, their addiction. Is that another thing that
it is? Everybody starts at the same. Like you're going to start on what I call a baby dose. Our medical director is going to assess you, and most of the time it's within a certain range. Right. And then every few days after that, you're going to get assessed at the dosing window by a nurse. Okay. She's going to do what we call a clinical opiate withdrawal scale. We call it a COWS. So we tell our folks, anytime you're feeling like you're withdrawing on it, talk to the nurse. Tell her you want a COWS.
Yes.
So a COWS. So they'll come up and move at the window. That's my favorite part. They're like, I need a COWS today. Because we want them to understand, like, they're in charge of their treatment. Nobody knows their body better than them. And if they're having breakthrough cravings at about 7 p.m., then that's not doing anybody any good. That's the witching hour anyway. So we know that the more we can get them on a stable dose, not high, but a stable dose that they're not having breakthrough cravings, then the safer that they're going to be.
Right. Tell me a little bit more about methadone and why it's so tightly regulated.
Okay. I have
why you have to go into a clinic and not get a prescription for it.
Yes. I would argue so much of it's still rooted in stigma. I like to tell people that methadone clinics are still the redheaded stepchild of the recovery world. And anybody who's been on any form of MAT, whether that's methadone or buprenorphine, which is prescribed as Subutex or Suboxone, will tell you, we don't fit in any recovery communities because they're mostly abstinence-based. Right. So I tell people, I'm like, treatment-wise, we kind of feel the same way. Like, people are like, oh, that's a methadone clinic. Yeah. And part of that is earned. Part of that reputation is earned. Okay. Methadone clinics did not do a great job from the 70s to the 90s on not being just dose and go. So they earned that name. So now we're trying to, to reframe that and show that we can be part of a comprehensive treatment program. But methadone in general is more tightly regulated because it's a narcotic. So they're going to dose every day for the first 90 days. After they start earning take-homes, they're going to be part of a state-mandated diversion control program. So anybody who's on methadone in the state of North Carolina is having to have what we call a medication callback for or bottle recall is what some centers call them.
Familiar.
Every 90 days. It's random. They come in, they do a drug screen. The nurse counts their bottles. We check bags. We see if it's been resealed. We see if it's been heat sealed. We see if they've put aspirin in it. And so we hear a lot, oh, I bet you see a lot. No, actually we don't. Diversion rates are not nearly as high as you'd think they are. A lot of that is still stigma, like, oh, people divert methadone. Sometimes people also divert insulin and antibiotics and benzos and all kinds of things. But because methadone is a narcotic, it is tightly regulated.
Okay, well that makes sense.
Yeah.
That makes sense, okay, so you don't offer any type of groups, as far as like support groups for people? And you do? Okay.
Absolutely, we do. Now I'm gonna speak to North Carolina groups here at both clinics because Right now, if you're a client at Clyde and we don't have a group that you love, you can go to the Asheville Clinic and do a group there if that works better for you. If you work in Buncombe County and you'd rather do a group there, just hit that one on your lunch break.
Yeah.
We do creative arts groups, which is pretty much an art therapy group.
Right.
It's just sometimes I don't have an art therapist clinically to say that, so we call them creative expressions.
Okay.
But it's just processing through a different way. We do music therapy groups. We do PTSD support groups.
Okay.
Right now we're doing those online and in person for people, because what we found with those PTSD support groups is that a lot of people really prefer the online piece because it doesn't feel as triggering to be in the same room with somebody who's processing their things. Just cool. We're going to keep that. Yeah. Online groups work, and that's what we're going to do. Yes. We also do grief groups.
Okay.
In the past, we've tried Medication Assisted Recovery Anonymous, like having a 12-step support group. We've had mixed engagement with it. Not everybody loves that format, and that's fine. Yeah. So I tell people, if you can find 2 people who are interested in doing something, we'll put you a group together.
Yeah. Interesting.
Because community's where it's at.
Yeah.
You know, one of my favorite TED Talks is the Johan Hari one about how addiction is the opposite of connection. Yes. And so I think, great, then let's just make all these, I want to give you as many possibilities for connecting as we can. Yeah. Because that's going to be another piece of your treatment.
Yes, absolutely. Yeah. Does a person, when they start medicated assisted treatment, do they go into it expecting it to be long-term, or would they expect it to be, just kind of a, stopgap or stepping stone to, or do most of them plan on it being long-term?
Well, it runs the gamut. Sometimes we'll have somebody who comes in and says, my goal is to do a year. I want to do a year on this, get my life in order, and then step down. Absolutely, we're going to support you in that. SAMHSA suggests 2 to 3 years for medication-assisted recovery, because it takes a little while for your brain to heal and start rebuilding some of those neural pathways that we've learned while using. Yes. So I've seen it successfully done in a year. I am a person who has been on medication-assisted treatment and was able, and now chooses abstinence as my recovery path. I try really hard to make sure that we give everybody realistic expectations of that. Data's not there. We don't have any good long-term data. It may be a year. It may be 2. Some folks may need a maintenance dose for the rest of their lives. And one of the questions that we get a lot is, well, how long? How long till you can fix this? We get this a lot from family members. Yeah. How long is my kid gonna have to be on this and then he's fixed? First of all, this is not a fix. Like that, we are very clear, like we don't ever want to perpetrate that, because we learned in addiction that if we try to shortcut, it rarely works. Yeah. So we're trying to also support that in recovery, like that there are no shortcuts. You're still looking at doing, you have your medication, but you're also building all of these other things: housing, environment, work, purpose, family, building a social structure. So when a person comes and says, I think I want to titrate down, I think I want to start coming down off my methadone, great. What we're going to do is I'm going to add a counselor to their treatment team. Okay. And then we're going to start, so now they have 2. Yes. They have one that they've been working with on all these things, and then we also have what I call a reentry counselor, who's going to work with them on like, what social supports can we put in place? What's your aftercare plan? What does this look like? We also do wellness RAP plans, wellness recovery action plans. Of what does it look like when you're not doing well? What do you want to happen if that happens? So that families can be involved in that and say, hey mom, if I have a relapse, here's what I want. Here's where I want to go. Here's where I don't want to go. Here's what makes me feel safe. Here's what doesn't make me feel safe. Because those are conversations that are really hard to have, maybe impossible to have in crisis. Yes. But when you're in a good place and you can say, oh, okay, when I start, missing 2 days of work at a time, or when money starts disappearing, these are what it looks like for me. And then that's helpful to families, because they're like, oh, I didn't know, and they can help get engaged in the process so much earlier. So we love a wellness recovery action plan.
Yeah, that's great.
Getting everybody set up with those.
That's great. Yeah. Okay, so here's a good question. Okay. What do you tell the person, and maybe even not the person seeking the treatment, but the family members or the lay person that says, well, they're just trading one drug for another.
Yes.
I hear that a lot.
Yes. That's one of my favorite, I like to call those methadone myths. One of my favorite things is to pretend I'm a myth buster and I can get to go in and say, here's the myth, and is this true or false?
Yes.
First of all, I ask them to just sit with a reframe. And I'll say, can you give me maybe 5 minutes to just ask a different question? And I'll say, if your son had diabetes and was just diagnosed with type 2 diabetes and you took him to the doctor and they said, he's gonna need insulin, would you ask that same question? Well, he's just trading this for something else. No, he's gonna need insulin, and he's also gonna need nutritional counseling. He's gonna need diet and exercise tips. He's gonna need all of these lifestyle changes. Is he gonna be able to come off insulin? Maybe. Maybe he's not.
Yeah.
Maybe his pancreas is gonna need that insulin. So I tell people, if it is, if we look at it with that model, same thing with like depression. Nobody's gonna shame you for taking Prozac if it keeps you safe.
Yeah.
But one of the things we really run into is, well, you're just trading one drug for another. You're just replacing it.
I've heard it.
You're replacing it. You're just doing it to replace that. Maybe, but what if that's what their body needs? What if we can step away and take all the story out of it and only look at the medical piece?
Yeah.
What if their brain needs this as part of a treatment plan that is helping them build a system of recovery? And usually that's when parents are like, oh, yeah, okay, well, that makes sense. So, and I think those are good. Another thing we work with our clients on is how to have those discussions with their family.
Yeah.
Because a lot of times people will think you're trading one drug for another, or you're going to be on this for the rest of your life, but won't say it.
Yeah.
And it comes out in all kinds of ways that disrupt family systems. So being able to teach our clients, hey, here's how you can have those discussions with your grandma who tells you this at Thanksgiving.
Yeah, that's great.
Yeah.
That's great.
Advocacy is a
Arming
huge
them.
piece.
Arming
Yeah.
them. Yes.
Or with other medical providers.
Yes.
We get that too. You know, someone will show up at the hospital for fluids, and because they have med seeking on their file, they'll say, I was treated like a junkie, Nicole. And I'm like, okay, great. Let's figure out how next time you can say, if you can't find me a provider who can treat me with respect, I would ask that you find me a different one. Yeah. And like, we practice those things. Like, we sit and we role play that. I want them to feel empowered with their medical care, with their family, so that they understand, I decide what my recovery looks like. Yeah. And if that's abstinence-based, great. And if it's not, here's what my recovery looks like, and give them the framework and the language to say that, and be proud of that.
That's great, yes. How do you measure your successes in this field?
I mean, the standard clinician answer is that there's a tool for that. Like, there's all these tools. But personally, I measure my successes when a person comes to me and says, hey, I did this thing I'm really proud of. And if that thing is they went all weekend without using IV, great. That's how I measure that success. If that thing is they just delivered a baby healthy, happy, and they want to, show me pictures, that's my success. Yes. Or when we have a patient who says, I'm ready to titrate down. Yeah. Will you support me in that? Yes, absolutely. That is how I measure success. Because I think in order for us to say success, for me, success is not going to be imposing my abstinence-based model on somebody else. Maybe abstinence-based isn't what's going to keep them alive, isn't what's going to help them build a culture of recovery. I want to support whatever that is, whatever they see that as. So that's how I measure success. But it also doesn't hurt when you get to snuggle a baby knowing that mama worked real hard to get that baby here.
Do you find there's stigma surrounding your job?
Yes.
Of course we know there's stigma surrounding the person that's struggling with, but when somebody asks what you do, where do you work, and you get the look, or what's that, or what? Yeah, I'm sure you have an answer.
I've been called a legal drug dealer more than once, and it's real hard. Yeah, it's real hard to not want to throw hands over that, because no, this is literally the opposite of that life. Yeah. I realize that people have different viewpoints, and I try to sit with them in that, even if I disagree wholeheartedly. And I use that as an excuse to try to educate them. But there is a lot of stigma. I tell people one of my favorite things is when we coordinate care with DSS, because nobody feels more shunned and stigmatized than social workers.
Yeah.
And I'm like, ooh, we're on the same page.
Yeah.
Like, my client hates you, but the rest of the world hates me. So we can work together on this. Like, we've got this. And that's another piece. Like, I want our clients to understand that we are here for them. And if they have DSS involvement, super. I want to know that caseworker's name. I want her to have my cell phone number. I want him to be able to call me and say, how is this client doing? Are they struggling? So that's one of the things we get off the table right at the beginning. Like, how can we support all of the people who are trying to help you right now? Whether that is doctors, social workers, pastors, probation officers. Like, who do you want involved? Who do you want at the table? Who's supporting their recovery?
That's great. Yes.
But we're still kind of the redheaded stepchildren of the recovery, and that's fine.
Well,
that's
yeah,
fine.
that's it. I mean,
Stigma smashing.
Yeah. There you go.
Yeah.
Stigma slayer.
Yeah, that's exactly right. Right.
So, what would you change? You know, if you had a
magic wand,
what would you change? You know, in the treatment facility world, in the way addiction is looked at, the way, and especially here in Haywood County, but you know, generally speaking, what would you change if you could?
Oh goodness. I think that in the treatment community, that there is still this really bizarre, and maybe it's because my training wasn't in treatment modality. Maybe it's because I'm coming from the other side. Right. But it's so bizarre to me, this idea of competition. Like, I don't care whether you're getting treatment with me or anybody else. I just want you to be safe and get treatment. Yeah. So if I could change one thing, it would be community over competition. We are not competing over client. I would love to say that there's going to be a cure for substance use disorder and that I'm going to be without a job and that I will have to learn how to scoop frozen yogurt. I would happily do that. Yeah. However, we know that with substance use and mental health, those are issues that are going to be here. There is no need for any sort of competition between treatment facilities or providers. And I think if I could change one thing, it's that we would all have those hard conversations to say, we're all in this for the same thing.
I'm disheartened by that.
I know. And also, if I could change another thing, my magic wand would be to have social workers give us another chance. Like, come on, talk to us. I promise we want to coordinate care. We're not covering.
Yes.
I hear that a lot. Like, methadone clinics just cover for their clients. No, I want families safe just the same way you do. So let's coordinate care. So it would be just a willingness to have those hard conversations.
All right.
Yeah.
Any last word? Any final message? Did we miss anything?
I have one time.
Here we go.
Because I know that you have so many parents.
Yes.
Who are part of the Share Project, and parents of kids who are struggling, and that's my heart. And so if I could say anything to parents who have children struggling with substance use disorder, is be open, talk to them. Don't be afraid that you're going to make them ashamed or uncomfortable. They are already feeling more shame than you could possibly imagine. Talk to them about their options. Find out what their recovery looks like. Don't have this tiny box that you think this is what it needs to fit in. Be willing to say, you know what? What does recovery look like to you? What's that gonna be? What is your family gonna look like? What is your work gonna look like? Because the same fears you have are the same fears they have. And they don't know how to talk to you about it. So to be able to say, you know, we want the same things, but I need to know what this looks like for you. Because here's what recovery means to me, and I'm pretty sure that's not what you're thinking. And so just to be open to having those conversations. That is probably the most beautiful part of my job, is when I have a parent who says, oh my God, I get it now.
That's great.
That's because great. It's not, you know, addiction's not the same for everybody. So it's silly to think that recovery would be.
Absolutely. Absolutely. All right.
Thank you so much. Thank you guys for listening today.
Thank you very much for your time.